I would like to thank the organizing committee for giving me the opportunity to talk here. So the topic is quite tricky in a different way because can I ask how many of you are radiation oncologists here? 1, 2, about 5%, 10%. So I think this is quite an important topic in terms of not only radiation oncology, in terms of kidney cancer and the management. That I don't know why the organizing committee wanted me to talk about this topic, but it's very interesting and very relevant across the globe. Going backwards there. So what we're going to talk about at the beginning is the historical perspective of radiotherapy in renal cancer. And if you look at, so in 70s, if any patient come to you, how do you diagnose at that time renal cancer? It's mostly symptoms. You palpate the kidney, and you probably have got renal cancer. And after that, in 80s or prior to 80s, you do a probably ultrasound and you find out, okay, yes, you have cancer. And then later on in 80s, you actually started finding small cancer in kidneys, and then you started having the early kidney diagnosis. And do we really need that in real life? Because over the years, we have now got more small renal masses diagnosed, but the cancer mortality remains the same. And again, as I was talking to you, that in 80s, yes, we started having that. But the role of radiotherapy has always been presumed that there is no role for radiotherapy in kidney cancer. That because of this trial that happened in the 80s, where stage 3 and stage 2 renal cancer patients had post-operative radiotherapy. And this is a trial where they had radiotherapy versus no radiotherapy. And you can see about 72 patients were enrolled. And at that time, they had 2D radiotherapy. We had discussions about SBRT, precision radiotherapy, earlier today. And it does show, and they had 50 gray in 20 fractions, and toxicity was extremely high. You can see that grade 3 toxicity was 44%, and grade 5 was 20%. So, therefore, it was concluded that for renal cancer, radiotherapy is a no-go. There's no role. And we know from 2000 onwards, we have more and more partial nephrectomy or nephron-sparing surgeries are coming up, and the total nephrectomy going down. And at the same time, you can see this second there, that the cancer-specific mortality remained the same. Now, if we look at modern era and the role of radiotherapy, how it's changing. So it's quite important to understand all those years when we had partial nephrectomy or total nephrectomy for kidney cancer patients, we realized a few things, which is that patients are not probably dying from cancer. They're dying from other causes. And recently, we had some renaissance in terms of radiation. And the cause of death for kidney patients mostly is non-cancer related, which is the chronic kidney disease getting worse and giving you more toxicity, more morbidity with cardiac morbidity and other causes. This is quite important to understand. When you're treating a kidney cancer patient with surgery, they may not die with cancer, they may die with something else related to the treatment. So chronic kidney disease is the primary driver of the overall cancer mortality in patients who are treated for kidney cancer. And this is the concept of the modern radiotherapy. We talked about SABR, when we give quite a high dose of radiation to kidneys or any organs. It works in a slightly different method than if you give 2 gray per fraction treatment, which are all there: necroptosis, pro-inflammatory signal changes, and the rest. And this is quite an important slide, I think, for you to understand that when you give 2 gray per fraction radiotherapy, you can treat most of the common tumors like squamous cell lymphomas. But when you give quite high dose radiation, we normally nowadays use it for renal cancer and melanoma. And this is also quite an interesting slide, just to look at this, that if patient has got 3 centimeter or less renal cancer, the treatment choices would be partial nephrectomy, cryo or radiofrequency ablation, and SABR. And you can see SABR ticks all the other sort of criteria that we took here. In terms of general anesthesia, they don't need it. You can treat the perihilar tumors, large tumors, yes, and it is a non-invasive treatment. And from this meta-analysis, you know that local control is 90% with SABR. It's quite important to find out. I mean, we're talking about not 2 gray, we're talking about 5 and more per fraction. And you can see that 26 studies, they looked at about 380 tumors treated in 372 patients. And toxicity is also very, very low. Grade 3 toxicity is only 1%. And these are the 2 trials, especially Fast Track 2. I think all the radiation oncologists should be aware that it's been discussed in so many forums, so many times. And this is the first time coming out in comparing. It's a pooled data for Fast Track 1 and 2. One was a feasibility trial where they looked at 33 patients, and then that moved on to multi-center prospective trial for SABR of 70 patients in various institutions with primary RCC. And you can see that in Fast Track 1, they were treated with single fraction 26 gray if it is 5 centimeter, but if it is, or less, but if it in 2 it was 4 or less, 1 fraction, and more than 4 is 3 fraction. And this is quite an interesting alpha-beta ratio. I don't know if it's too much or not, but alpha-beta ratio is the radiosensitivity that we normally look at from radiation oncology point of view. And if your alpha-beta ratio is low, you probably do better with hypofractionation. But that's one of those theories that we used to feel that alpha-beta ratio was reasonably high for kidney, therefore it was not very hypofractionation, or more dose per fraction didn't work, but that's proven to be not true. And if you look at this pooled data, you can see most of the patients were reasonably elderly, 70 plus, and good performance status. They were mostly early stage. And I skip that. And they had quite importantly, their mean EGFR was about 50 to 60. Quite interestingly, the adverse effect was very, very low. Only 7% had grade 3 adverse effect. Those are mostly flank pain or abdominal pain, and no grade 4 or grade 5 toxicity. Remember that 15, 20 fractions, all those years back in 80s, they had significant 44%, 20% grade 5 toxicity. It's not there. And you can see here the cancer-specific survival was 100% in 1 year, 98%, and 98% 3 and 5 years. Freedom from distant failure was also very good, 97% first year. Local control, 100, 98, 98. And the actual reason for death is again something else than cancer itself. And the rate of EGFR fall from the SBRT is about 10-15%, and then that actually plateaus at 2 years, which is the phenomena that we know. So from this pooled data, only one cancer death that happened in 103 patients, and toxic profile is pretty favorable. And maybe the toxic profile of more abdominal pain we could have avoided by giving basic treatment like steroids and other treatments. So what came out of all these is that SBRT for kidney causes less changes in EGFR, which is quite important because that's what drives patients' mortality. So NCCN guidance in 2013, if you look at, it was not mentioned at all, radiotherapy for kidney cancer. And now it's mentioned in stage 1, stage 2, stage 3. Let's have a thought about the metastatic disease in terms of kidney cancer. And this is a meta-analysis which is presented in 2023, but this is only for the TKIs, not the immunotherapy for the kidney patients. And here you can see hardly any benefit from TKIs, marginally improving survival benefit, no impact on local control, and obviously it's very, very expensive. But we know from our data for the oligometastatic SABR data, the local control could be as high as 90%. This is 28 studies, 1,600 patients in 8 countries, showing in all parts of the body very good control from SBRT. So the thought process is that if you have a limited number of oligometastases, you can get a good local control with SBRT, which you don't get with systemic treatment with TKI. Grade 3 toxicity is extremely favorable, with 10-20% with TKIs. Toxicity is mostly local, and then systemic treatment is obviously systemic. Discontinuation rate is extremely low, where it is 10-20% for systemic treatment. And obviously, cost is hugely different. And for our country, especially Bangladesh, we probably have to be very, very careful about who we are offering systemic treatment in metastatic setting. And in oligometastasis, we feel some of the patients may be cured with SBRT. Obviously, question is mostly who or which type of patients would benefit from SBRT in renal cancer in the metastatic setting. Obviously, oligometastasis is the area that we should be looking at. And when it is widely metastatic, systemic treatment is obviously indicated. Still, we have some unknown factors, both for local and localized or metastatic setting. You can see risk stratification still not 100. I mean, we don't know it fully. We are not sure who to surveil. Some go for surveillance all the time, and when to offer treatment versus no treatment because of the size between 4 and 5. There's some ambiguity there. Certainly, with the localized treatment, we still have the options of partial nephrectomy versus focal therapy versus SABR. And when we are doing SABR, what margin shall we give? All those technical aspects from radiation point of view. And from metastatic point of view, as I said, when it is widely metastatic, yes, systemic treatment, but when it isn't, should we be treating primary and then sit tight and do nothing and then treat the oligometastatic areas, or treat all of them? And should we give them systemic treatment and oligometastatic SABR at the same time? a lot of questions in there, but certainly it's a quite exciting time for radiation for kidney cancer. And so far in the talk today, we touched base all these points, that localized RCC increased in incidence without changing the mortality since 1970s. It's really important to understand that. And we do have lack of randomized data. And yes, we know from SABRE data that it doesn't cause, or probably the least culprit in terms of reducing the EGFR amongst all the other modalities. Risk stratification and other comorbidities we've got to think about when we are offering any treatment to this group of patients. It is safe, less toxic, and effective, and less expensive. And obviously, in the oligometastatic setting, it's probably coming up. There was a phase 2b trial just presented in Astro from University of Texas, where they looked at patients with the SABRE for the oligometastatic patients, and they demonstrated definite reduction in terms of need for systemic treatment more than a year. Thank you very much.